يسر لي أمري واحلل عقدة من لساني يفقهوا قولي اللهم إني أسألك علما نافعا رزقا طيبا وعملا متقبلا شفاء من كل داء. Vaginal discharge. It is most common presenting complaint of female attending obstetric department. Excessive vaginal discharge may be physiological or pathological. Prevalence. It has been estimated that approximately 1/3 of the female patients may complain of abnormal vaginal discharge. It can occur in females of all ages from neonatal to the post-menopausal period, and it is quite common during pregnancy. Many clinics have reported that 70% of the pregnant women manifest abnormal vaginal discharge due to lower genital tract infection. Normal discharge. Floccular inconsistency, whitish and non-malodorous, no smell is there. Normal pH is acidic ranging from 3.5 to 4.5 due to lactobacilli which convert glycogen to lactic acid. Secondary fermentation of the endocervical mucus by vaginal flora also contribute to low pH. Normal flora includes lactobacilli found in 96% of the women, concentrations 105 to 108 per milliliter, protective effect by interfering with adherence to epithelial cells, facultative organisms such as diphtheroids, streptococci, E. coli, ureaplasma urealyticum, mycoplasma hominis, and anaerobic organisms such as peptostreptococci, bacteroid, and fusobacterium. They are all responsible for the normal flora. Causes for vaginal discharge. Physiological. Age dependent, that is neonatal and infant. Number 2, pre-puberty. Number 3, childbearing. Number 4, post-menopause. Excessive secretion. In pregnancy. Number 2, sexual arousal. Pathological. Non-infective chemical irritation. Antiseptics such as bath additives, deodorants, detergents, spermaticides, douches, and perfumed soaps. B. Foreign bodies, IUCD, retained materials, retained tampons, retained sheaths such as gynecological conditions, endocervical, and C part, that is infective causes, cervicitis. Causes by number 1, herpes genitalis, number 2, mucopurulent cervicitis, caused by, that is gonococcal, non-gonococcal, chlamydia positive and chlamydia negative vaginitis. Number 1, that is bacterial vaginosis. Number 2, vaginal candidiasis. Number 3, vaginal trichomoniasis. Childbearing age. Causes for increased vaginal secretion during childbearing age is as follows. Number 1, mid-cycle stimulation of endocervical glands by estrogen. Number 2, exogenous, that is semen of recent ejaculation. Number 3, mid-cycle discharge is sufficient to keep the vagina moist and usually does not stain the other garments. It may be associated with Mitchell's-Merz or mid-cycle unilateral pelvic discomfort. Post-menopausal period. You can see in this picture, this is the atrophic vaginitis. In the post-menopausal period, the vaginal epithelium becomes thinned out and the color changed from pink to yellowish orange because of the lack of estrogen. There is atrophy of the vaginal epithelium due to diminished estrogen secretion, thin serous discharge, occasionally blood stain and associated with itching and burning, small area of granulation and ulceration, along with slight vaginal bleeding may develop. Most common cause of abnormal vaginal discharge is atrophic vulvovaginitis in the case of menopause. Now, on examination, we have to take the history. Source of discharge must be determined. Perineal discharge could originate from vagina, cervix, urinary bladder, and rectum. Ascertain the following attributes of the discharge, such as quantity, duration, color, consistency, and odor. Symptoms include itching or burning, external dysuria, that is burning, micturition, and dyspareunia, that is painful coitus, which may be superficial dyspareunia, that is coitus pain at the beginning, and deep dyspareunia, that is when the when the coitus is at the peak or the depth of the vagina is attained by the male organ. Obtain history of the following: prior similar episodes, sexually transmitted infection, sexual activities, birth control methods, last menstrual period, douching practice, antibiotic use, general medical history. Systemic symptoms such as lower abdominal pain, fever, chills, nausea, and vomiting are there. Physical examination: appearance of discharge, erythema and edema of the vaginal mucosa, whether the vaginal mucosa is red or not. Then pH levels. Diagnostic tools: pH, nitrazine paper, wet preparation, microscopic examination of the discharge, clue cells of bacterial vaginosis. Potassium hydroxide preparation dissolves cellular debris leaving pseudohyphae of the Candida. Whiff test, which gives the fishy odor of the bacterial vaginosis in culture. Bacterial vaginosis medication: oral metronidazole 500 mg BD for 7 days or clindamycin 300 mg BID for 7 days. Number 2, vaginal metronidazole gel 0.7% BID for 5 days or clindamycin cream 2% for 7 days. No treatment of the sexual partner is needed. So you can see in this picture discharge. Here again discharge in the cervix and discharge in the vagina. Candida medications: clotrimazole 1% cream 5 gram intravaginally for 7 to 14 days or 2% for 3 days, or miconazole or teoconazole or butaconazole or turconazole, and oral agents fluconazole 150 mg orally single dose. But this single dose has to be repeated after 72 hours for at least 2 times more. And in chronic cases, we have to give weekly 1 capsule for 4 to 6 weeks. This picture shows the whitish discharge of candidiasis varying from thin to curdy consistency, cottage cheese-like. Trichomonas vaginitis medication: metronidazole 2 gram orally single dose or tenidazole 2 gram orally single dose. Alternative regime: metronidazole 500 mg orally twice a day for 7 days. Here in this picture you can appreciate the flagellated protozoa, Trichomonas, and also you can see in wet preparation how it looks like. Thank you. I hope my lecture will help you in your studies and in medication and in your examination.